Morning, dear student. So today we are going to discuss the one case of neurology. Okay. So Dr. Sam is here to help me. Dr. Sam, can you just introduce your patient?
My patient was Sahadev Mawla, right-handed, 64 years old male from Kanchanpur, Saptari, who was farmer by occupation. He was Hindu, literate, was admitted from emergency to medicine ward and was examined by me. The patient's informant was a patient, his wife, and his son, and information was quite adequate and reliable.
So exactly. So here he have also mentioned this information is adequate and the reliable. So when we are supposed to write the adequate mean when the patient give us that much of information which is sufficient enough to make some definite conclusion, then we have to write the adequate. Okay, and reliability means that when on asking the patient, the patient is answering the same thing, then that's the reliable information. And we have to always mention that thing because some patient may be suffering from psychiatric disease, or they might be having delirium, and they might not be giving the adequate information and the reliable information. So before going ahead, as a doctor, we have to always mention regarding the adequacy and the reliability of the history. Yes. uh, so another important thing he have mentioned is the handedness of the patient. So is there any significance of like mentioning the handedness of the patient here?
Yes, it is quite significant because in neurological case, when we take history and when we elaborate the case, then the handedness, if the patient is right-handed,
Yeah.
then we can say that the patient's dominant hemisphere in
Mm.
about 90% of the cases it lies in the left side.
Yeah,
And
yeah.
if the patient is left-handed, then in about 50% of the cases, the dominant hemisphere is the right side.
Okay. Yeah. So if I am right-handed, that there is 90% of chances that my left hemisphere is dominant, and the dominance of the hemisphere. So why we say this hemisphere is dominant? Because the hemisphere where there is a speech center, then we call that hemisphere dominant hemisphere. So let's suppose if I'm a right-handed person, and if I have in that scenario my left hemisphere is dominant, and if I have a right-sided hemiparesis, then my left hemisphere may involve, and I may have also the speech problem. Okay, speech problem. So that's why we need to know about the dominance of the hands. It's important in when you are presenting a patient with some neurological disorder. So were the presenting complaints in your patient?
The presenting complaints were slurring of speech for 2 days, facial deviation for 2 days, and weakness of right upper limb and right lower limb for 2 days.
Yeah, so there is a history of slurring of speech, facial deviation, and weakness of right upper limb and lower limb. So he had mentioned this presenting complaint in chronological order. Chronological order. We should always maintain that thing, and we should not use the some medical terminologies. Okay, just we can write like slurring of speech and facial deviation, or weakness of right upper limb and lower limb, rather than writing the hemiparesis. We should always write in non-medical terms. Okay. So looking at the history, it seems that your patient might be having some neurological disorder. Yes. So in the neurology, okay, we'll discuss that thing later on. So can you tell a little bit more about his history in the HOPA?
The patient was apparently well until 2 days prior to the presentation, when his wife noticed slurring of speech at around 8 a.m. in the morning. So, according to the patient, he woke up at around 6:30 a.m. On that morning. Then he visited bathroom, did his morning rituals, and suddenly at around 8 a.m. he developed slurring of speech and could not speak as before.
Okay, okay.
Uh, on trying to communicate with his wife noticed that he produced incomprehensible sound only with great efforts. However, he was understanding what was spoken to him, and his speech was unclear. Words were meaningful, and he also followed the spoken command. The slurring of his speech persisted thereafter.
Mm.
And his wife also noticed that he developed deviation of angle of mouth to the left side, which was visible on attempting to talk. And she also noticed that his face became asymmetrical, and there was a drooling of saliva and water from the right corner of his mouth. And patient also noticed difficulty in chewing solid food as food particles accumulated on the right side of his mouth. However, there was no difficulty of swallowing.
Oh, yeah.
There was no history of fever, pain behind the ear, or appearance of vesicles, eruptions behind the ear. There was no history of tingling, numbness, or burning sensation felt in that area, and nor there was any history of drooping of eyelids or blurring of vision.
Mm, yeah.
And patient also said that he noticed weakness of his right upper and lower limb, which was sudden in onset and that persisted. Initially, he could not grasp objects with his right hand and could not lift his right hand above his head. He also had difficulty buttoning and unbuttoning of his shirt,
Mm, yeah.
and he felt that his right lower limb was weaker than before, and as he could not lift right lower limb above the level of ground, and he could not stand bearing weight on his right lower limb,
Mm.
and he fell down on the ground as he attempted walking.
Yeah.
However, his right upper and the lower limb did not felt flabby, nor there was any history of pain or numbness over the affected areas.
Okay.
And there was no history of head injury, fever, abnormal body movement, altered sensorium. There was no history of dizziness, sudden loss of vision, or transient loss of consciousness prior to these symptoms. And all these symptoms were gradual and without wearing and worsening of the symptoms. There was no history of altered perception of smell. There was no history of blurring of vision, obvious eye deviation, pain and numbness of the face, and dryness of the mouth or eyes. There was no history of altered taste sensation, tinnitus, or decreased hearing. There was no history of nasal regurgitation of feeds, swallowing difficulty, or deviation of the tongue. There was no history of stool or urine incontinence, and there was no history of personality change or antisocial behavior.
Mm. Okay. So no, and then okay. Next day we'll discuss later on. We can discuss that thing later on. So it's a very good history. So I think we our patient have the three problems here. One is slurring of speech, facial deviation, and weakness of right upper limb and lower limb. So what might be the cause for the slurring of speech? So what might be the cause for this thing?
Mm. As these symptoms are abrupt in onset, so we can predict some vascular type of
Oh, yeah.
etiology in
Yes.
this neurological disorder. So slurring of speech could be, it is part of dysarthria.
Oh, yeah, yeah, yeah.
Um,
So yeah,
or,
so you
or it could be
yeah,
aphasia.
aphasia. So so history favors more in favors of aphasia or dysarthria.
Um, it favors more in aphasia.
Aphasia, yes. Basically, yeah, I think so. So in the speech, the speech, like there are three types, basically three types of speech disorder. So one is aphasia, and another one is the dysarthria, and another one is the dysphonia. So aphasia is basically the there is a problem in the part of the comprehension and the production of the sound at the level of the brain. Yes, because like when someone speak, then the transmission like travel from our ear, then vestibular nerve knob, then ultimately it goes to the temporal lobe. So there is an area called Wernicke's area. So the basic function of that area is to comprehend the sound. So this is in the temporal lobe, and in the frontal lobe there is one area which is the Brodmann's area number 44 and 45. The main function of that area is called the is a production of the sound, is a production of the sound. So if there is any problem at the level of Wernicke's and the Broca's area, then we call that aphasia. So that is aphasia. So dysarthria is basically the problem in the articulation part. Patient can understand, patient can speak, but they have some articulation problem. And dysphonia is a patient can understand, patient can speak, there is no even articulation problem, but the intensity of sound is relatively low. So like when we are analyzing our history, it seems that our patient have aphasia. And basically I think it is motor aphasia, I think, yeah, because patient is
Yes,
trying to
yes.
say something, yeah.
The patient is understanding what was spoken to him, but
Yeah,
patient production of sound is
yeah.
impaired.
So
So
he has difficulty in like producing the sound. So I think there is a problem in Broca's area. So probably which lobe of the brain is involved in this patient?
it is the frontal lobe
Frontal lobe,
where
yeah.
the Broca's area lies, the
Yeah.
inferior
So
hemiparesis.
anatomically, yes. So regarding the onset, the patient has the acute onset. So it probably it's a vascular event, and that vascular event probably has like occurred at the level of frontal lobe, as frontal lobe. So it may be a case of stroke. Yeah. So regarding the facial, like facial deviation, yeah, there is a facial deviation. You have also taken the history of like there is no pain behind the ear and appearance of vesicular eruption and like these things. So, like, what is the significance of asking these things when you're taking the history of facial deviation?
Because we have to rule out the some causes of facial deviation like herpes zoster infection
Yeah,
of the ear and ear canal, that is known as Ramsay Hunt syndrome.
yeah, yeah, yeah.
So to rule out, we
Mm.
take history
Mm.
of blisters or some painful eruptions around the
Yeah.
ear and around the ear canal.
Yeah, yeah, yeah. So yes, Ramsay syndrome. Yeah, in the it's like they can have the vesicular eruption is usually in the external auditory canal. Yes. So you have nicely taken the history regarding the weakness, but you have also like taken the history. You told that okay, like there was no history of head injury and abnormal body movement or altered sensorium. So is there any significance of asking this a head injury, like why you're asking?
Um, because just to rule out some causes like also
Mm.
head injury with traumatic bleeding and some intracranial hematoma
Yeah, yeah.
hemorrhage can also produce these kinds of symptoms.
Yes, yes. So yeah, definitely this our patient have hemiparesis, and one of the cause of other than the like stroke, like this things can be manifestation of like subdural hematoma or sometimes subarachnoid hemorrhage, or sometimes there might be like hemorrhagic transformation of space occupying lesion in the brain. Yeah, 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 you have nicely taken. So, so if there is hemiparesis, then historically, I think we can like say who like where is the problem, like anatomically, whether it is in the cortex or internal capsule or brain stem. So how we can know that thing? Like,
Since there is involvement of probably facial nerve,
mm,
so we can expect that the lesion lies above the level of bones.
bones or above the
Both
level of bones?
bones,
Yeah, yeah.
bones are above the level of bones, and he also has, by our history, he also has motor aphasia. So it has involved the cortex. So
Yes.
it cortical
Yeah,
lesions,
yeah.
I believe.
Yes, so aphasia is basically a cortical functions, and like our patient has aphasia, probably like there is a cortical involvement. So another important thing when you are analyzing the weakness part, like if someone has the cortical weakness, then they have like disproportionate, disproportionate in severity of the weakness. Like some patient may have the weakness more in the upper limb than the lower limb, and some patient may have weakness in more in the lower limb than upper limb. And in case of internal capsule, because like internal capsule stroke is quite common, and if they have internal capsule stroke, then they can have the dense hemiplegia, that is weakness is equal in right upper limb and the right lower limb. In case of brainstem, definitely they will have they can have the hemiparesis, but they will have the history of involvement of the cranial nerves. Like in case of midbrain, they can have involvement of third
third and
and
fourth
fourth,
nerve.
and in the
In
pons,
pons, five and six nerve.
yeah, five, six, and seven
Seven
and
and eight
eight.
also.
Yeah, yeah, yeah. And in the in case of the middle oblongate, they can have like 9, 10,
19,
11,
11,
and 12.
12.
Yeah, but our patient have like involvement of only facial, not so facial nerve. But the clue here is the our patient has aphasia. So provided I think our patient have the involvement of the left frontal lobe, left frontal lobe, left frontal, and the event is vascular. So. So, is there any significant past history of our patient?
Um, Patient was a diagnosed case of systemic hypertension since last 10 years, and
Yeah.
he was under oral medications for
Mm,
that.
mm,
And patient also has a history of diabetes mellitus, which was diagnosed 4 years ago,
yeah.
and for that also he was taking oral medication.
Mm. So basically, our patient have history of hypertension, diabetes, and taking medication.
Yes, sir.
Definitely, I think these are the risk factors for stroke. Yeah. So, like, did he have history of the transient ischemic attack in the past or stroke in the past?
There was no such history
Oh,
of
yeah.
transient ischemic attack or stroke.
So another important past history that we have to take is that heart, like a history regarding the cardiac disease. You have taken here,
Yes.
yeah, because 3 months ago, patient developed severe left-sided chest pain due to which he was admitted in BPKHS, and you are said to have some
Heart
heart
disease.
attack. Yeah,
Yes.
was discharged. So basically, because one of the cause of the stroke is the cardioembolism, and we should always ask the history regarding the heart disease. Yeah, I think in the past history we should ask history regarding hypertension and diabetes, and sometimes heart disease, or previous history of the transient ischemic attack and previous history of the stroke. Yeah,
Yes.
yeah. So personal history, I can read for you. He's a reformed smoker. I mean that he left the smoking for last 1 year. Yeah, I think for reformed smoker means
Yes.
that thing, and he had history of consuming more than 100 sticks per, like in his lifetime. If someone had history of like taking more than 100 sticks in the lifetime and had left the smoking for last 1 years, then that is called the reformed smoker. Yeah, he like he's also alcoholic, and further like for the MBBS student and the junior resident, we have to calculate the pack year for the smoking and the unit for the alcohol, and we have calculated that our patient had a pack year of 3.6 pack year of smoking, and regarding the alcohol, there is of consumption of 5 unit of alcohol per week. Yeah, his appetite and the sleep is normal. Regarding the family history, yeah, we have to make the pedigree chart definitely at least for 3 generation, and we have to also ask regarding the uh, any cardiovascular event or cerebrovascular accident in the family, because there are some like causes of the CVA which runs in the family. That's why we need to write that thing. Uh, Regarding socioeconomic history, you have to write everything about the socioeconomic history, then the drug history, and the yeah, we have to write these things. Okay. So in the just so in the neurology, it's like uh, so this is a clear cut case of the stroke because uh, so so there is some screening question for the stroke. Do you have any idea for that? Yeah.
We have one screening question is B fast scoring question that we ask about the B stands for balance. Patient is maintaining balance or not. E for eye problem, and F for facial deviation
Yeah.
and A for
A for
asymmetry of
arm weakness,
arm
like
weakness,
that. Yeah. As
and
per
S for the
slurring of
slurred
speech.
speech, and T for the time.
Yeah, yeah. So our patient has the in the B fast there is no problem in balance, there is no problem in eye, but definitely there is problem in face. There is facial deviation and arm weakness, and definitely slurring of speech. So I think there is like there's more probability of the stroke in this patient. So you know, like I think we can write that thing provide the risk factor hypertension, diabetes, and heart disease. But definitely we need to differentiate whether it is ischemic stroke or hemorrhagic stroke. So how can they do that?
So, if patient presents with weakness
Yeah.
or inability to move upper limb or lower limbs,
Mm.
and at the same time the onset is sudden, and patient that is associated with history of vomiting, severe headache, then we can expect that maybe hemorrhagic.
Yeah, right. So there is a hospital in Thailand called Siraj Hospital, and they have like derived one scoring called Siraj score, and as you're perfectly right, like there are like there are they have given the formula, but so if someone has the I make up like. क्या भन्छ त्यसलाई abbreviation like LVS, like loss of consciousness, vomiting, and headache. If someone has the loss of consciousness, vomiting, and headache, apart from these symptoms, then we think what about the hemorrhagic stroke? So, epidemiologically, ischemic stroke is more common than hemorrhagic. So, worldwide, like there are 80 to 85% cases of stroke are ischemic, and around only 15 to 20 are the hemorrhagic stroke. Okay, okay. Mm, so, anatomical, so provided it's the ischemic stroke at the level of frontal lobe, and risk factors might be hypertension, diabetes, and the heart disease. So we have to also write. We have to also take the history regarding the like the complication of these conditions, because the one of the important component of history taking is like writing about the complication history. Like so. What are the complications you have seen in like last 3 years?
Patient can develop increased intracranial pressure, raised ICP.
Yeah.
That is one complication that may develop within or after few days, like 3 days or
Yeah,
5 days.
yeah.
That is the thing that we have to ask in the history.
Mm.
The other complication could be aspiration,
Yeah.
and aspiration leading to aspiration
Yeah,
pneumonitis,
yeah.
and other infections like urinary tract infections.
Yeah.
These are the acute complications.
Complications, yes.
And when the patient is admitted, we have to ask and see about whether the patient has developed bed sore, pressure ulcers because of the bedridden conditions.
Yeah.
That is another thing.
Yeah.
And later on, we also have to check for some neuropsychiatric problems, as these patients are more likely to develop depression or low in the lower mood. So these are the few complications.
Yeah. Yes, perfect. So we have discussed the history of the patient who have presented with the slurring of his speech, facial deviation, and the right upper and lower limb weakness. So we have also discussed about the past history and the personal history, socioeconomic history, and drug history. So we think when we have to write a summary after writing the history and like summary of this case. In the summary, we can use some medical terminologies like hemiparesis and aphasia, or like that thing in summary, and we have to make some provisional diagnosis in the summary. Okay, I think we have a nice discussion, and it will be useful for our MBBS student. Okay, thank you for your attention. If you have any comment, then you can write in comments. Okay.